My name is Cristie Cole, and I will be the moderator for this session. I'm currently a fellow in the bioethics department at the Cleveland Clinic. We've had a very dynamic day today discussing and thinking about several of the ethical issues that arise through the treatment of various pediatric non-epileptic patients. Earlier this morning, we specifically explored those issues that arise in the treatment and diagnosis of adult psychogenic non-epileptic seizure patients. Some of those issues included the hidden curriculum of patients, physicians, and trainees, classification, documentation, and coding of the diagnosis of PNES, and caregiver burden. These issues are equally applicable to the treatment and diagnosis of pediatric and adolescent PNES patients, but they arise in a very different circumstances. These different circumstances are largely driven by the developmental stage of this patient population, as well as the daily social interactions that they have, including both family and peer interactions. As a result, there are unique ethical issues that arise for this population that deserves and warrants our special attention. Today, we will highlight two areas that are uniquely troublesome for this patient population: the family and the school environment. We will begin first by exploring those issues that arise as a result of family dynamics and understanding of the diagnosis. Dr. Rochelle Caplan will be our first presenter. Dr. Caplan is currently a professor of psychiatry at the University of California, Los Angeles, and has directed the Pediatric Neuropsychology Clinical Program for over 20 years. She has conducted NIH and EFA-funded studies on psychopathology, cognition, language, and obstacles to mental health care in children with epilepsy, as well as features of and risk factors for pediatric non-epileptic seizures. Dr. Caplan chairs the Pediatric Non-Epileptic Seizures Subcommittee of the American Epilepsy Society Non-Epileptic Seizure Task Force and has received national and community awards in recognition of her research, mentoring, and teaching of young faculty, child psychiatry fellows, and residents. She will begin to lay the foundation for our discussion by highlighting the differences between the adult and pediatric and adolescent patient populations and how these differences impact the diagnosis and treatment of each population. She will also explore the role the patient's parents and family can and does play in both the diagnosis and treatment of these young patients and the obligations of the physicians and other treating clinicians to facilitate that role in order to provide the best treatment for these patients. We will then hear from Dr. Tatiana Falcone. Dr. Falcone is a staff physician in the Cleveland Clinic's Neurological Institute. She focuses on child and adolescent psychiatry and is currently conducting research in the psychiatric comorbidities of patients with epilepsy, as well as in a school intervention project to decrease bullying in children with special needs. She is also a past recipient of the APA Transformational Leadership Award, has served on the APA's Board of Trustees, and completed several fellowships in public and community psychiatry and child intervention prevention. Dr. Falcone will explore the impact the school environment has on the clinician's ability to effectively treat pediatric and adolescent PNES patients. She will focus on the social stigma that is present and that these patients face every day, both by peers as well as school personnel. She will also touch upon the potential for not only interdisciplinary, but also institutional collaboration, highlighting the role of school nurses and counselors and their corresponding ethical obligations. In addition to our presenters, we also have two respondents who will provide their insights from their own experiences in working with this patient population. Dr. Jane Timmons-Mitchell is a senior research associate at the Begun Center for Violence Prevention, Education, and Research, the Mandel School of Applied Social Sciences at Case Western University. Her work focuses on researching and disseminating evidence-based practices for children, youth, and families. She is Associate Clinical Professor of Psychology in the Department of Psychiatry at Case Western Reserve University School of Medicine, and a member of the adjunct faculty Mandel School of Applied Social Sciences. Kristine Jares is a clinical social worker on the Pediatric Epilepsy Monitoring Unit at the Cleveland Clinic. She was previously a therapist for 15 years, working with children, adolescents, adults, and their families. She's also a graduate of Case Western Reserve University's Mandel School of Applied Social Sciences. And before we hear from our first presenter, I would just encourage you to listen. As you listen to the presentations, comments, and discussions that we hope to have here today, I encourage you to pay attention to a primary theme of the competing obligations of clinicians to provide clinical treatment and comprehensive care to this patient population, or as Dr. Stagno stated this morning, the need to consider the patient as more than just a checklist of symptoms. Ultimately, we hope this session will encourage you to think of new ways to resolve the ethical conflicts that arise as a result of these competing obligations. I would also encourage you to consider the effects pediatric and adolescent patients' developmental stage and their daily social and familiar interactions can have on the clinician's ability to administer effective treatment, as well as the potential for both interdisciplinary and interinstitutional cooperation to enhance patient care. And Dr. Caplan.
As Cristie mentioned, one of the things I'm going to be talking about is the difference between adult and pediatric NES. And I think that clearly when we're talking about children, we need to be talking from within a developmental context. And that's very, very different versus the situation in adults where we can already talk about personality disorders, which are very frequent in adults with non-epileptic seizures. Now, the way the illness, and I think Grant's previous talk really prepared the listeners to hear kind of what I'm going to be talking about in kids, because in the developmental context, the child is part of the family, the child and the parents sort of go together, and we really have to have an understanding in terms of the narrative, if you will, of the child and the narrative of the parent, and we'll talk about that in a minute. So from the perspective of the child, this is a cry for help. And it is a cry for help because the children present actually with hidden problems that often involve their social relationships or their social behavior, school-related issues or family dynamics. Now, in contrast to adults, can you see? Oh, you see. Okay. So whereas there's a high rate of abuse in adults with NES, that is not the case in kids. It does occur, but it is not as common as is found in adults. There's also, in children, there's a high rate of epilepsy. In other words, a demonstrated epilepsy, so that these kids are actually even more vulnerable to the development of non-epileptic seizures, and that is in contrast what happens with older adolescents and adults. And again, the outcome in adults is, I would say, more poor than that in children, in particular if children get treatment. Now, as I said before, this is a cry for help, and the cry for help does not mean I am faking. And that is really very important to remember, because what occurs here is the child is in the situation that Grant described before. He called it aporia. David Taylor has called it the predicament. The child is in a situation where there is no way out. The child feels there is absolutely no way out for what appear to be unsolvable problems, and pretty much this is channeled through the body. What the underlying mechanisms are, this whole issue of body, mind, etc., I'm not here to solve, but clearly this is an illness which demonstrates it very nicely. So what are these unsolvable problems that children have? And we need to divide it into those kids who have an epilepsy diagnosis and those kids who do not have an epilepsy diagnosis, although the problems are actually not that dissimilar. But what we know is there's a high rate of comorbidities in children with epilepsy. And these cause significant stress, in particular if they're undiagnosed and untreated. And these include learning difficulties, social stigma, side effects of anti-epileptic drugs, comorbid anxiety, depression, ADHD, and then there is the whole psychosocial, psychodynamic aspect of the impact of the illness on the family. What about the kids who do not have a past epilepsy diagnosis? Well, the stresses, and as I said, the stresses are similar, but these again are undiagnosed, untreated stresses that involve language, some kinds of language deficits, and we'll talk more about that in a minute, and language-related learning deficits, which actually impact children's literacy in terms of reading and writing, very, very important skills for children in our modern society, math, and this is not language-related, but math problems, problems with attention, and or too much of a workload if we are in an environment of kids have to get top grades, get into top colleges, compete with everybody else. Then there's social difficulties. Social difficulties can be an impairment in social skills. Kids are not in the in-group. Kids experience bullying. And as you'll see in my next slide, also associated psychiatric diagnoses might usually involve difficulties with social skills. Here's the perfectionism I was talking about beforehand, which can express itself in terms of schooling. It can express itself in terms of competition, which is extracurricular. We're cheerleaders, we're volleyball players, etc., etc. And then there are family-related problems or trauma, as I mentioned beforehand, but it's not frequent. And additional stresses for kids who develop NES who do not have epilepsy is undiagnosed anxiety, depression, ADHD. So as you see, the two groups have similar stresses, but the mechanisms are probably the same thing. So why are these problems unsolvable? Why are these children in a predicament? Why are they in the situation where they feel there is absolutely no way out? Well, there's several factors. The first factor is that the child does not express their difficulties. Why does the child not? Not these. Let me phrase this in a better way. In some cases, children do not express their difficulties, and in some of them, it's because they have undiagnosed language deficits. In some of the kids, it's because they are unable to tune into their feelings, and in particular, their feelings of negative affect. Sad, unhappy, angry, mad. Then there's another, and they can have both of these, and it's not infrequent that the kids both have difficulty to tune into their feelings and have difficulty expressing them. But then there's another situation in which kids are able to express these, but they fall on deaf ears, meaning that the parents do not pick up or do not hear what the child is communicating. And very often what we hear from these kids is no one is listening, they don't get it, they don't understand. And the other aspect of this illness is that these children often have unsuccessful problem solving. They're not good problem solvers. And as such, the problem solving technique that they adopt is one of avoidance, which is not a very successful problem solving technique. So rather than doing the homework, if I've got some learning difficulties, I'm not doing my homework. Rather than going to my volley team practice, I suddenly am not feeling well and I've got reasons why I'm not going. Again, none of this is done at the conscious level. Now, from the developmental perspective, if we continue this discussion on why the problem's unsolvable, kids need their parents to help them problem solve, right? They cannot manage, if a child has an undiagnosed learning difficulty, the child's not going to call up the nearest educational therapist and say, listen, I need your help. Okay, so they need their parents to help them problem solve, which is the reason why the communication really has to fall on open rather than on deaf ears. So what the situation is that ultimately for both these groups of kids, with and without epilepsy, the child with NES has problems that are not apparent to the parents, and in fact, the parents misinterpret the children's avoidant behavior as kids being lazy, kids being bad, kids being spoiled, and or a combination of both. And this, of course, is going to make the kids recoil even more and not want to tell their parents about all the problems that they have. So the child is in the situation where I need help. Kid has been unable to solve the problems and needs help. So what is the aim of treatment of these children? First of all, and I'm including the comprehensive evaluation as part of the treatment, because actually the treatment starts from the minute that the clinician, be that the neurologist, epileptologist, and or the mental health care person, if we are so lucky to have them involved in the very beginning, the minute they start establishing rapport or start working with the child and the parents. So VEEG, video telemetry, is clearly the gold standard, as you know, but that in itself, demonstrating that these are non-epileptic seizures, does not mean that the child has an underlying conversion disorder. So that children have to undergo a comprehensive evaluation to identify the very specific psychological profile, which I don't have time to talk about now, but maybe in the discussion, to identify what the child's underlying diagnosis and difficulties are. Then the next part of the treatment is actually the short-term treatment, which involves treatment to stop the non-epileptic seizures or the events. And the most important part is the long-term treatment, which basically the aim of it is to help the child be a successful problem solver, in contrast to what's happened now. How is this done? Well, the therapy usually needs to be individual for the child and therapy for the family. In terms of medications, unnecessary anti-epileptic drugs, if the child does not have epilepsy, will just compromise the child's cognitive and emotional control skills even more. Where indicated, psychotropic drugs, if the child has a psychiatric diagnosis that can respond to medication, they're indicated. And very important, all these kids need, and Tatiana will talk more about it, is an assessment of their learning skills and intervention within the schools, and if need be, social skills training and other extracurricular help based on what is determined as the underlying issues. So what are the obstacles to this? The obstacles are that the parents come into this situation expecting a neurological diagnosis. Nobody has prepared them for this diagnosis of non-epileptic seizures. That's why it's very important from the beginning, when one establishes contact with the parents, to slowly help them understand that different factors can cause seizures. How is this done? Well, the feedback is very, very important. And how the feedback is done, really it needs to be sensitive, and I think Grant emphasized this very nicely in his talk, needs to be sensitive to what the parents can hear and where they are at. And it needs to be done separately for the parents and for the child, because their narratives are different and what they understand is very different, and where they are and their ability to hear the diagnosis is very different. Who's this done by? It's done by the pediatric neurologist, epileptologist as the team leader, and a mental health care person there who's done the assessment. And what is the most important aspect to avoid? That is any possible suggestion that the child is faking. So what are the ethical implications here? Insensitive feedback will make these parents go doctor shopping. And we need to prevent that at all costs, because they will always find doctors who will continue to treat their children as if they have epilepsy, and the underlying psychological issues will not be dealt with. The other thing is anger towards the child. Parents get very upset if they think their child is faking, and we have to protect the child from that. If not, when we have an insensitive feedback, basically this vicious cycle is just going to go on. It's important to know that untreated, these children go on to be maladapted individuals who in addition then develop depression, have poor learning, social skills, and the family functioning just pretty much goes downhill because of the child's problem. And the system, the medical system, costs a fortune in terms of ER visits, doctor's visits, not to talk about all the medical complications like kids getting into status. And I'll stop there. Thank you for your attention.
Thank you, Dr. Caplan. Dr. Timmons-Mitchell, do you have any responses?
Thank you, Dr. Caplan, for your extremely informative presentation. I do want to pick up on a couple of things. From my perspective, in addition to the things that Cristie said, I'm also a clinical psychologist and have been for many, many years. And so I think of the Bronfenbrenner ecological model as being a way of thinking about children not only nested within themselves individually, but within their families, and then within schools, and then within communities and neighborhoods and all of those things. So one of the things that I found very interesting was where you went to eventually with the extracurricular, and I want to come back to that in a second. But one of the evaluation techniques that I have found to be the most pragmatically useful in dealing with a full range of children is to focus on functional analysis of behavior. And the functional analysis of behavior approach, I think, is one way of addressing sort of the how and the why of the unsolvable problems, because then you can kind of generate hypotheses and test them and work on those things. And it sort of helps to illuminate not only what some of the conflicts are in terms of communication, but as a clinician, it helps me to be on track with tracking where the child and the family are, that critical issue of what they can hear and when they can hear it. I think that an approach that I often have taken, and I saw in your earlier slides the mention of cognitive behavioral therapy for the children, which certainly depends on the age and developmental stage of the child, because a very young child can't take advantage of it. So a competing frame that I might think about is a resiliency framework, which I think is useful for all children, to try to stress, yes, the child needs an accurate and appropriate diagnosis, and yes, we need a plan of action that addresses those things directly, but also that if you focus on resiliency, that is using every child's strengths to address their needs, and designing a plan of action. You know, that old adage, nothing succeeds like success, I think is extremely true. And children, even children who are very compromised, even children who see themselves as not being successful in many situations, you know, they might go into school and not feel successful in school, or they might not feel successful in, you know, arguing with their big brother. But if they can, you know, go on to a soccer playing field and have a successful experience, it changes their interaction of themselves with the world. So I guess what I'm suggesting is that all of those things I think are true, and that we need to add this component of the other ecological factors and the feedback that children get from them.
Thank you very much. Ms. Jares, do you have any comments, responses?
Well, I come from the point of view where I work as a social worker on the pediatric unit, and I'm there right from the start of when the patient is admitted through diagnosis and then them leaving. And it's interesting to see the whole process and how it unfolds. And quite a bit of the time I feel like my role is to educate the parents as well as the child or adolescent about what, you know, this non-epileptic event diagnosis is. And it's very difficult, you know, for them to wrap their heads around what that is exactly, especially if they've been diagnosed with seizures in the past. And oftentimes I find that the child gets it, they understand it. You know, I'll say to them, so does it make sense to you that maybe, you know, your body's acting this out because you've got all advanced classes, you know, you're head of this club, you're involved with this sport? The kids do get it. Now then there's the parent. They can be a totally different story, not always, but quite often the parents are the ones that really have a hard time grasping this. And so I'll have to work a lot with them so that they understand it and they can get their child the proper treatment. And as I said, you know, it's a process that unfolds from the point of admission until they're discharged. And when they first hear the diagnosis, it can be very difficult for them to, like I said, wrap their heads around, to get it, that, you know, emotional, psychological stressors could be causing this. But then, after they've had myself go in, Dr. Falcone will go in, the nurse practitioners to kind of reinforce it, you'll see that with a lot of the families, not all of them, but they'll slowly begin to kind of get it, you know, and understand it. So I just wanted to comment a little bit about that and what the process is like.
Thank you very much for that. Do we have any questions? We can turn this to discussion for the audience. Go ahead.
I don't see pediatric patients, but do we know what is the risk of a child to develop non-epileptic events if mom or dad, or mom and dad, have non-epileptic events?
Is this working? Yeah. Actually, in the study that is ongoing, that Sigita Pliopoulos is the PI, and one of the centers, it's a multi-site study, is Dr. Falcone's Cleveland Clinic. What we found is, and we actually found it in a prior pilot study, in the histories of these parents, there's a very, very high rate of all kinds of somatic illnesses. And not non-epileptic seizures, but, you know, lots of physical illness, so that the communication style in these families is through their bodies. It's very interesting, right? But, you know, sick kids, that's how you get your attention. Again, that's an assumption. It needs to be demonstrated, but...
I see sometimes adults with asthma. What about the kids? Can they have it?
I can't hear her.
What about like
Sorry.
kids? Like, is it genetic? Like, what about
Oh, you... What you asking? I'm sorry, excuse me.
No, she asked, like, if the parents have it, can the kids learn else behavior?
Oh, I am sorry, I misunderstood. Modeling is a very, modeling is a very, very important component, and it's not unusual, as you heard in the story this morning, that there might be a cousin who has seizures, but that's not always the case. In fact, I've seen quite a few cases where it just came from the television. Because these days we see epilepsy all over the place, but the modeling can be a mechanism, yeah.
Given that modeling is fairly prevalent, so some doesn't always occur, but it's prevalent, if a patient is modeling based on parents or siblings, is it ever appropriate for the physician to take steps to separate them from that environment if treatment isn't effective?
You know, the decision to separate a kid from a parent, it's not an easy decision. I think when one sees that a parent has non-epileptic seizures and the child has non-epileptic seizures, it indicates to us the scope of the treatment that needs to be involved, both in terms of the child and in terms of the parents. In some cases, the indication for separating the child from the parent, hospitalizing the child, for example, would very often be because the child is having so many events, the school says they can't deal with them, and pretty much the child being at home, the child will be having events all the time and the parent can't deal with them. Then there's a reason to separate them, but that's only to get the initial non-epileptic seizures under control, to do also acute intervention with the parent, and then to get the child back. But I don't see any ethical reason or medically based reason unless this child is being severely abused by the parent or by physically or sexually or whatever. But you know, if it's just sort of family psychodynamic related issues that are not putting the child at any kind of safety problem, then I don't see a justification. Other people might have a different opinion.
So you would look for a medical necessity to place the child in a hospital, and it would be a secondary effect that they've been taken out of that environment. that perhaps they're modeling the behaviors of the...
Yeah.
Okay.
The goal of treatment is for these kids to continue to live in their families and for these families to problem solve, as you mentioned so nicely. Resiliency, we need to find what are the strengths of the kids, what are the strengths of the families, and you need to build on those in the therapeutic process.
Thank you. Dr. Ford.
So I very much enjoyed your talk, Dr. Caplan. Ethics, I think, can be thought of in a variety of ways. The way in which you used it on the screen was very appropriate and good in highlighting what our ethical obligations are. And where I become challenged is when you take it to the next step to say, when we have more than one ethical obligation, we can't fulfill them completely both. How do we, ethical dilemma. What kinds of boundary cases might we have? And you gave a great one just now. We value keeping people in the community and not in the hospital, but we also value having them maximally treated. We value having them embedded in their family and solving it, but we value, so sometimes we have to overcome the obligation to keep the community to be in the hospital. I heard you very strongly saying we advocate for to avoid doctor shop. Do whatever you can. I don't know the exact words, but suggesting that that's of a very high priority. You might be willing to give up some other things in order to preserve the ability to that they don't go doctor shopping. I suspect that you advocate for having venues for them being heard, right? Being heard.
Yeah.
The voice. Can you reflect, or maybe your colleagues also, what kinds of boundary issues do you get? How far does that obligation, where then you transgress a boundary of privacy, or how far is getting to be too far for advocating for being heard, or being taken off non-epileptic medications, epileptic medications, or to keep them from doctor shopping? How far is too far to go in preserving any of those?
So the assumption here, it's kind of a narcissistic assumption, is we're better doctors than the guys out there. So we rather have you with us who we understand, right, the great UCLA. We understand what's going on. Those guys, we don't know what they're going to do with you. But in that context, and this again relates to what Grant was talking about, many of these parents don't understand the illness, and it takes a while to work with them until they understand the illness. And many of them can't even hear this diagnosis. And so one of the things, for example, one of the things we would work with the parents, and this is an easier thing for parents to buy, and I've had quite a few families where we've done this for a while until they're ready for this diagnosis, is that stress can cause seizures. Let's figure out the stresses because parents want the seizures to go away. Okay, they might not want to call them non-epileptic seizures, but they want them to go away. Let's find the things that are stressing Johnny out, help Johnny with these things so that the seizures will get better. In the meantime, we're working with the kid. In the meantime, we're working with the parents. And ultimately, they do buy into this. The amount of time varies. There is a very small subgroup of parents who, despite all this, take their feet and run. Now you might say to me, what about those? Do we report them to DCS or do we not? And I'd be very interested to hear what people say. I can tell you that we have decided not to do that because we feel that the services that DCS provide, at least in California, and we're bankrupt, so we're in big trouble, those services are worse than anything that the child is receiving right now at home, even though it's not in the best interest of the child. But this is a real ethical problem.
Thank you.
I really think taking children from their home should be the last resort.
Mm-hmm.
That is a trauma. Look at our foster care system that persists through adulthood.
Absolutely.
It is a form of institutional societal abuse.
I agree. And it has not proved itself. Even in the kids in which there is abuse, Unfortunately, the results have not been good, but that's another story.
My other question is really an ethical one, and the difficulty in communication with school, for example. Many of our cases clearly relate to what's happening in school, and we have to communicate something to the school nurse, and it's extremely, the parent is on one level, you're at one level, the patient's at another level, and you're trying to help the school nurse decide what to do, what words do we use, and what ethical boundaries do we push in trying to help the school come to help this child without just kicking them out and saying go and home down.
I think Dr. Falcone is
That's
going to
a
address that.
great question, and Dr. Falcone's presentation will address that. And please ask it again. So she could get up here earlier. Does anybody else have any questions or comments?
I have a comment.
Thank you.
I think it's very important what Dr. Caplan just said about the communication in the initial diagnosis. Like, that is probably the key when we're really trying to make a difference in the doctor shopping, because I think it takes a while for the family to understand the implications of the diagnosis. And, you know, as some of the previous panel was pointing out, it's hard, you know, sometimes for the epileptologists, they give the diagnosis and then the role comes, so whose patient is this patient? Is the patient just the psychiatry patient, or is now is not my patient anymore? And what we see is it takes a while for the family and the patient to process this information. It might take up to 3 visits from the time, and this information has to come from the neurologist and the epileptologist, because even if the family meet with us 10 times, and we're trying to help them understand what are the stressors, unless they hear it many times from the neurologist, they still gonna try to find, they might have a fantasy thinking maybe the next center is really going to find what is happening, and maybe we don't have the answer yet. And that's why we keep pushing the family to keep looking for more neurological causes and not focusing on what psychological treatments we can do to help this kid move forward.
Can I just add something to this? So one of the most important thing is, and again, this brings us back to the stuff that Brian was talking about this morning, that the docs are very busy and they don't have a lot of time. But one of the things we found is that if after the feedback is given, we then meet the parents again, not on the same day, they've had a time to rethink this and then try and go through with them what they understand what was said to them. And that processing is so important, because very often they might have understood everything, and then on the way driving home on the freeway, it's like, this Dr. Caplan doesn't know what she's talking about. Dr. Sankar is full of it. There's nothing wrong with my kid, blah, blah, blah. So they come back and we have to reprocess the whole thing. If we're able to do that, and as Tatiana says, it might take more than once, that prevents the doctor shopping. It's really essential, really essential.
The process of when you give this information, what you were saying about you're there, and it sounds like that's with an EMU evaluation where they're in for 4 or 5 days.
Exactly.
Many times you don't have 4 or 5 days. Insurance companies give you 23 hours, and or they come into the emergency room. You make your diagnosis on an EEG and observation in the beginning, and you have 24 hours with your suggestions to ethically approach this complex problem in such a short time.
Well, in the short stay, I think it's, you know, we don't know where the family is in a very quick evaluation like you're talking about, but you still need to lay it on the line, is my opinion, and let them know that, you know, well, according to the video EEG, we don't see any changes, we don't see any seizure activity, so this looks like it's non-epileptic. And then, you know, to refer the family to get some further education and some counseling. We don't want it to stop right there, because the odds of the parent and the child adolescent really getting it and understanding it, it's not going to happen. So it's very important that there's going to be some follow-up, you know, that they're told in the emergency room, you know, you really should go for an evaluation, psychological, and possibly to see a psychiatrist also, just to further that educational process so that they can understand. And whether or not they follow through with that, you know, we don't have control over that.
Just quickly, just to summarize, I think what everyone's saying is that it's a process, that the communication of the diagnosis and then people's understanding is a process that takes a while to digest. And the short answer that I would give to how to do that is that I think everybody should be trained in motivational interviewing, because motivational interviewing is the answer of how you would do that over time. That's a whole set of evidence-based processes that have been developed over the past, I think, maybe 20 years, and they're effective in communicating medical information in medical settings to a whole variety of patients around a whole variety of issues. And almost all social work schools or other CME places would offer training in that, and they're wonderful videotapes.
Can I just add something, though? I do think that the ER is not the setting to give this diagnosis. In other words, my concern is that the parents are not prepared for this and they will go doctor shopping. And I think, you know, in the ER we can say, if an EEG was done, that we didn't find anything. We need to do more evaluations. We want to see you in clinic next week. And then, you know, start working on them, start doing the evaluation again with the kid, with the parents, to see what the stresses are.
Dr. Ford.
So I think this is a great example of where different values are articulated, that in the one case you don't want to withhold any information, and in the other case, other side, you also want to give information in the place where it will be maximally effective. In that balance, I see a difference of opinion and judgment, and making that explicit, I think, is very nice. Connected to the sort of the delivery of information, I think I'd seen on your slide you suggested informing the child and the parents separately.
Yes.
Thinking about adolescents, I pick whatever age you want for the example. You value being transparent with your patients as they move towards adulthood, and you value trying to maximally help them in the family situation. So how do you think about when it is that the patient, if ever, should know everything, and when you might challenge when that separate disclosure, if ever, is ethically preferable, or the separate?
Okay. Typically, NES occurs, if it occurs, it's in kids 7+. Usually you don't find it. Any kid, the feedback should be given separate to the kid than to the parent for several reasons, including ethical reasons. The parents often get very upset when they're given this feedback and immediately say, you say my child is faking. You don't want the child to hear that. That's one thing, because that gives the kids such guilt and makes them feel that nobody trusts them, etc. It's not helpful to the child. The second thing is the feedback to the child needs to be given at the child's developmental level so that the child can understand it and be willing to work with you or whoever's going to work with. And it's simply not helpful for the child to hear these terms and all these EEG terms, etc. It's not helpful. So I hope that's enough of an explanation.
Say a 16-year-old who's worried that you're hiding things by not respecting them as a.
Oh, you mean you're talking about an adolescent needs to be with the parent, is what you're trying to say?
That's what I'm saying. Is there other times when
Oh, I see.
you tell the adolescent separately, and then you include them in the family?
Yeah. Oh,
yeah. Respect for them, transparency, and in fact, I can imagine it'd be helpful.
Right.
Because they're thinking maybe it's my fault.
Right. No, and we bring the kid in. In other words, I didn't mention that, but if the kid is ready and if the parents are ready to be in the same room, sometimes they're not, then clearly we bring them in because this is a family issue.
And I think the important point is you do this separate at the beginning because you're trying to protect the kid from the parent reaction. Because the initial reaction is he might be faking. Why are we going through all this time at the hospital, time missing from school, if you are, like what the parent might think is if you are faking. So we are having that meeting with the parent to trying to explain this is a real disease, and what we're going to do is trying to help you identify the risks so we can move forward. I want to talk a little bit about what do we do at the school level, and some of the issues that we see. So one of the issues that we see is even when the patient was diagnosed with non-epileptic seizures, the initial recommendation is for the patient to continue to take the antiepileptic because they feel there might be some social stigma at the school. So what is the role of the neurologist or the epileptologist trying to help combat this social stigma? And are the antiepileptic medications being used as placebo to help the kid avoid social stigma? Is it ethical for the clinician to conceal that they're prescribing that medication from a placebo perspective, and is it ethical to do it from the parent? And one of the things that we see is really hard for these patients to understand what is happening. So sometimes we see that despite that the evaluation showed that the patient had non-epileptic seizures, the patient continued taking the antiepileptic medication because not at that point because they were having some psychiatric comorbidities or treated for the psychiatric comorbidities, but more because the neurologist or the epileptologist feel it's hard to help that family make that transition. So we feel like education is very important. Education gives the parent and the school empowerment. So we believe that the parents have the right to know what is happening. What is important is how we're going to communicate this to the parents and what are we doing to make this transition easier. As Dr. Caplan pointed, one of the things that we see is when the parent consult the clinic, they're looking for a neurological diagnosis. So when you're giving an explanation that is not neurologic, they might feel frustrated. They might think we don't know enough, and that's why they might go doctor shopping. So I think if the parents know, it will be easier for them to help understand the treatment plan. And I think if the diagnosis of non-epileptic seizures was confirmed, the antiepileptic medication should be weaned off if the patient has no comorbid epilepsy. In the case of children, we know that the incidence of epilepsy and non-epileptic seizures is much higher than in the adults. So how we can share this information for the family and how we can share this information to the school, because I think one of the most important plans is like now that we know that these episodes are non-epileptic, what is the role that the school is going to take? So a common mistake that we see is that sometimes the treating physician don't want to stop the medication thinking, maybe there's another neurological concern that we are not seeing, and that, if we already have the video EEG that shows that there's no epileptic changes, is promoting like a false belief in the patient. So the patient might still think they have epilepsy because they are taking these medications. Also, we have to think about the risk benefits of using anti-epileptic medications when they're not medically indicated. We know that a lot of the anti-epileptic medications may have a lot of different side effects from the cognitive perspective, from the mood perspective, that maybe the patient don't need. I think the key is information delivery. I know it's hard to try to convey this information to the parents, but unless we take enough time in that moment when we're communicating the diagnosis, the parents are going to get really stuck in the diagnosis and they're going to keep looking for an answer. So as we say, we think the information has to be delivered in different steps. The first step is definitely the epileptologist or the neurologist telling the patient what's happening. Then the second step, the rest of the team reinforcing the information. Then the third step, trying to understand what the family understand about what's happening. and then what the child understands what is happening to them. So we feel there's important role for the team, everybody communicating the same information from the family, and we hearing after the information was conveyed, what did the family understood and what is the engagement that they have with the treatment plan. So after the parent learn about the diagnosis from the team, I think it's very important to check how much they understood. I think it's very important to double check that the kid is not faking the symptoms. I think that's a common belief for the parent, for the school, and for the peers of the child. Check what are the stressors that might be contributing to the non-epileptic seizures. And something that we see very frequent is when you ask these patients, are there any stressors? Most of the patients will say, no, everything is perfect, there's no stressors. And when you go through the list of things that are going on at home, you know, the parents are getting divorced, they just lost their house, they're failing all the grades. And for some reason, we see a disconnection between the child being able to connect the stressors with what's happening. And I think the more that we're able to connect the episodes with what's happening in the child life, the more that we're going to be able to help them move forward. But until that happens, we're going to keep having these episodes. So the more that the family understands, the less doctor shopping is going to happen. And if they keep looking for another doctor to find an answer, they still feel like they don't understand the reason why this is happening. So ultimately, this is really affecting the child. Is really because if the parent doesn't buy the whole idea that this is psychological, then they're going to keep trying to understand, is this neurologic? Maybe there was not enough video EEG that was done, so maybe if I go to a different clinic, maybe if I go to a different neurologist, I will find a different answer. So when I think about some of the patients that we see that have seen 3 and 4 other epileptic centers, and what happened and how come they finally decided to change. And I don't think it's because it was, the evaluation was different from any of the other centers. I think the way that we deliver the information focus a lot in how the family is perceiving the disease and taking into account what they're going through and trying to follow up in the next month, because even if the patient has spent 5 days in the hospital and they know they have non-epileptic seizures, that month after, they might still have concerns that maybe, you know, yes, this is non-epileptic, but for 5 years the patient was taking anti-epileptic medications. How? So even when the patient and the family report that they understand, they go home, process the information, they come back 1 week later and they still have issues trying to understand how this could be possible after they took medication for 5 years. So is it permissible for clinicians to instruct the child to attribute the PNES to more socially acceptable comorbidity? I find really hard to be able to communicate some of these issues with the schools. I think it's very important that we communicate this to the school. I think it's very important that we have the consent from the family to have an open line of communication. The peers is a different issue because we see that kids with neurological disabilities have a lot of bullying problems. So how, when we're communicating that the condition is non-epileptic to the other peers, is that putting the kid at more risk for bullying? And is our moral responsibility then to protect the kid? I think it is. So we have to try to figure out, you know, are there any bullying or emotional abuse that can happen if this is communicated to the peers? I think that the line of information should be open with the school, but with the peers it should be limited because it might impact the way that the peers are perceiving the child, and it might affect the child more. So what do the school should know about the patient conditions? I think it's very important the school nurse and the school staff know that the events are non-epileptic, that there should be a plan of what happened after each episode. One of the things that we see the most is the school try to send these kids home and say, listen, when you're better, come back. But what we see is if that happens, it's going to be harder for this kid to come back to school. And what we recommend is that these patients are reintegrated quickly to the school. The medications the patient take, they should be on record in the school, and they should know specifically what to do when this happens. So what are some of the ethical challenges that the school nurses face and the counselors before the diagnosis of the PNES? So I think it's very important for them to do parent education. So when someone is diagnosed with epilepsy, they also should know there's risk for non-epileptic seizures, and we should try to understand, was the patient evaluated with a video EEG to make the diagnosis of epilepsy? Most of the times it is, but there's some cases that the patient has been treated as having epilepsy for many years, and then after 5 years we find these episodes were non-epileptic. So what are also our obligations for educating the child? We think it's very important that according to the developmental stage, we inform the child as much as they're ready to know, and try to help them identify what are the stressors before the episode started. So after the diagnosis was made, what are the challenges for the school nurses and the psychologists? I think it's very important that we keep an open line of communication, and the consent has to be given by the family. And the school nurse have to have all the information, because one of the things that we see is when the school nurse doesn't know and the kids continue to have these non-epileptic events, they're going to keep treating these non-epileptic events as seizures, and this kid is going to continue to be sent to the emergency room and continue to go to the same process that he was or she before the diagnosis was made. So what is the role of the school after the diagnosis was made? I think it's very important for the school to help decrease any stressors that we're seeing they're happening for that kid. So when we're thinking of the stressors, you know, we have to think about cognitive performance. We have to think about, is this patient is struggling in school for any other reasons? Are there any issues with attention deficit disorder? Are there any problems with language or cognitions that should be addressed? So we recommend to do like a full neuropsychological evaluation to try to understand why this is happening. So there should be a school plan to deal with this episode. So we have to inform the nurse that they shouldn't be calling 911, or the patient should be sent to emergency room every time that the patient is having the event, that the student should definitely go to a different room when they're having the episode, and after they're doing better, promptly return to the classroom. And you know, if there's any way that we can have someone at the school that can help think the child to see what are the stressors that are causing some of these episodes, that could be helpful. I think, you know, provide more emotional support, identify like if there are any maladaptive communication strategies. I always call the nurse and try to say, okay, let's think about, are these episodes happening in the same classes? Or when they're happening, was it like during recess time? Are there any stressors that we can think that are making this child more vulnerable? Is this person someone who has like multiple somatic complaints, like headaches, stomach aches? And we know some of these might be related to anxiety. And you know, we have to focus in all the strengths of the patients. Like, what can we do to focus on the participation in the school and the things that they can keep doing? Because if we send them home and we try to get them home school, we'll be focusing more on disability, and we have to focus on improving their ability to get better. So, or, you know, are there any academic problems that are a stressor that need to be addressed for this child to get better from their non-epileptic seizures? So one of the frequent school concerns that we see is school refusal. Kids stop going to school. It might be secondary to anxiety, it might be secondary to school phobia, it might be secondary to bullying. The way that the other kids perceive these episodes might be impacting how they relate to the other kids. The somatic complaints might be impacting how much attention they're paying to their classes. Are they coping right? Like, one of the things we see, as I say before, we see there are many stressors, and even though everybody can see the stressors, the child takes a while to see how the stressors relate to what is happening. All these difficulties coping impact how the child is performing at school, and how, sometimes for some families, the academic performance might be the only thing that is being identified as a stressor. So the mom might come and say, well, he was an A student, and now all the grades are D's and F's, but we don't see like all the other stressors that this patient is going through, like divorce, or, in adolescence, like fights with the girlfriends. So we have to think about what are the stressors and how we can help them. Also, family stressors are very important.
Thank you, Dr. Falcone. And do we have any comments from either Ms. Jares or Dr. Simmons-Mitchell?
Yes, thank you. So thinking about schools, and I think this is where we may actually come into a pretty big ethical dilemma series of clashes. I know Dr. Falcone works with schools a lot, and I've worked with schools supervising teams of therapists actually in the schools. And I got to tell you, I don't know how many of you have actually worked in schools, but a school is a completely different place, and it has its own set of everything, and it has to. I've done a lot of jobs in my life, but I realized that working in a school is something I could never do, because you have at least 500 bosses and every day, and you have to respond to everybody, and it's all out there in the media, and everybody's in 30 different ways ready to say that you did a terrible job. So I also have a lot of empathy, which has been built up over a lot of time working with people who work in schools and working directly in them. I also have a friend who has been a school nurse for over 30 years, and she was kind enough to talk with me at some length about this presentation. So I want to share with you just a couple of words from her, because I think they're instructive. One is that, the first incidence of a child having something that looks like a seizure, whatever its etiology, often occurs in the school. And that may not be something that we think about a lot, but by the time they get to the medical facility, they may have already had something happen in the school, and the school has already had to put their action plan into place, whatever that is. Then the second part of that is that the schools do have rules and procedures that require all of these things that they have to do. Again, back to the functional analysis of behavior thing, right? What it looks like, maybe not what it is. And so how to help them get around those things, takes quite a bit of doing. For example, in the needs assessment that Dr. Falcone did, it's 60%-ish of the school nurses said that their procedures require them to call 911 every time a kid has something that looks like a seizure, whether it's PNES or not. So that puts you into conflict with, but this isn't the best thing for them in their own individual treatment plan. And so how do you end up resolving that dilemma? The other thing that Dr. Falcone mentioned, which I think is something to be really, really familiar with, is the process of how you go about negotiating for an individual child what they need in the school setting. I mean, there really are only a couple of ways of doing that. One is if you get them a 504 plan, which is named for the line in the legislation, at least in Ohio. And the other one is if you get an individualized education plan, which takes the full evaluation that Dr. Falcone was mentioning. And so you have to get something written in that has the force of law in order to have these exceptions, because if you don't, it's not just unhelpful to suggest to the school nurse or the counselor that they do things this way. It puts them in this immediate conflict, and they are not able to respond to it. So those would be my thoughts.
Thank you. Ms. Jares?
Along with the 504 and the AEP, just like when a child has actual epilepsy, they have seizures, there's a seizure action plan. I think it's also very important as a team approach with, the behavioral health clinician, with the parents, with the student, to formulate some kind of an events action plan and what can be done, so that the school has some kind of a guideline as to what they can do to help out with the process. And just to comment about the stress of school on these kids, it had been stated that a lot of times these events will occur at school for the first time. And, you know, we notice in the PMU that we usually have more admissions with children that are diagnosed with the non-epileptic events around the time of the first report card of the school year. You know, there's a significant difference in the amount of kids that are coming in and seeing these diagnoses.
Thank you.
Even though patients that have electrically abnormal seizures, epilepsy, but also the patients with non-epileptic seizures, our instructions when they go home is of a plan of action when they have one, and that usually does not involve ER and 911.
Right.
So can we have the same plan that they would have from home in the school system, and if that makes the nurse, the principal, or whoever more comfortable,
Right.
call the physician's office to let us know and guide them what to do.
Mm-hmm. And
Those usually happen in normal work hours, so either the treating physician or some backup would be available.
well, and the action plan can be formulated, like I had said, with the behavioral health clinician, signed by that clinician. It could be followed up with a phone call by the clinician explaining and educating a little bit more to the nurse. Unfortunately, I do want to mention that so many of the schools don't have nurses anymore. You know, we've seen in Cleveland severe cuts of the nurses in the school. They're just not there anymore. So then there's going to have to be someone else within the school, the counselor, or somebody that the child perceives as somebody that they're comfortable with and they're safe with and they trust, you know, I think is real important.
Can I respond to that also? So in California, we don't have this luxury of school nurses already for many, many years. So school nurses are pretty much out of the equation. And the other thing that we have in California is what you were talking about. Every kid who has a seizure, they send them to the ER. They're not going to change it because they're covering themselves for insurance purposes, etc. So that, as I mentioned in my talk, the first step is control of the non-epileptic seizures. And it's really, this first step to get it going soon is very important because that's what helps us get the kids back to school. So what we have is we pretty much institute homeschooling until the kids' seizures during the day are controlled enough so that we can reintegrate the kid back into school, because our school system refuses, period. The private schools, forget it. They don't want to see these kids until seizures are controlled. But the schooling is essential also because they have these deficits. We need to work on these deficits, etc., etc. Or if it's for social reasons, we need to give them the social skill training in the meantime so that they can get back to school.
How often do you see kids that, let's say they have surgery done, they are seizure-free for a year, and now I'm not having the extra care that I was getting from mom and dad. School doesn't give me the extra care, and now they develop non-epileptic seizures for some reason.
Yeah, we see those cases, and the patients get better. But you have to think as the epilepsy as a chronic condition, and these patients cope with all the difficulties that they have with a lot of help. And suddenly you become well, you have no more epileptic seizures, you're doing even better at school, and you start losing some of your supports. So that put some anxiety, and it's hard for them to cope. And even, when you put some of those services back, you still see that the kids continue having the non-epileptic seizure. So we think it's very important to get some, therapy involved to try to help them, adapt to the new life situation. Yeah.
But in response to your question, how often do we see it? It's pretty rare. This is not usually the cause for non-epileptic seizures. It's pretty rare.
Olivia, do you want to- Go ahead, Dr. Ford.
So coming back to the what you tell your peers at school, for some people, telling a lie by omission or directly can sort of eat away at you. And in fact, sometimes when you don't tell
I think it's very important to protect them against their peers. And we see a lot of bullying to a point of like physical problems. Like I have seen kids going to the ICU for trauma because of the bullying. So I think anything that we can do to protect them against how the other people are seeing the problem is important. So it's the same. When a kid has a suicidal attempt and they just leave the hospital and they come and ask us, so should I tell my friends that I just attempted suicide? I will say, you know, you're the owner of the information. You know how much you should share. But I think, you know, I'll probably tell your close friends what's happening. But if you're going to tell all the school, some people are going to see you different and are going to act really different, and some of them are going to be bullying you. So I think our first responsibility is to protect them. So that's why when the parents ask me, do you tell all your patients, do you share this information with the peers in the classroom? I'll say no. Yeah.
And can I just support that? We've just been talking a lot in just after my talk about this issue of parents not understanding what non-epileptic seizures are. Kids at school definitely don't understand what non-epileptic seizures are, and the only thing they take away from it is, oh, so you're a faker. That is a major source of bullying, as Tatiana mentioned, and it's not in the best interest of these kids, many of whom have difficulties with their social relationships. So I don't think this is an ethical issue. I mean, I feel fine. I'm not telling the kids to lie. Usually what we say to them is that, you know, everybody knows they went to the hospital. And these, again, as I said, UCLA is such a good place. We figured it out. And now we've put them on the right treatment and the kids back. And very often this is what the families tell their friends, because they don't want everybody talking about it. And, you know, you've got to go with what they feel comfortable with. If they want to say this is non-epileptic seizures, that's fine. But very often they just say it's under control. The UCLA experts figured it out. And I'm not getting commission for advertising UCLA. So sorry, I didn't understand. Who are you saying, how do we describe it, to whom? Well, to the school?
We have a learning disabled child with a hemiparesis at school who's doing badly, having spells, and actually getting secondary reinforcement from older girls when he has the spells and he loves it. So we figure out what's wrong, and that he's in the wrong class, but they refuse to change him because their view of his psychological testing, which is usually poor, is that he should be in a slow learner class, which is really over his head, even though it looks like he does that on paper. So how far do we go now? Do we go to the state?
I mean, I think it would be interesting to hear what other people say, because clearly when kids are in a class that's not appropriate to them, it's going to express itself behaviorally.
I know there are other questions and we want to get to them, but I think the quick piece of that would be there are a lot of assumptions that you put forward that I think need to be unpacked, and I think that's best done in a collegial discussion with the people at the school rather than coming from the angle of saying you're doing it wrong and we know better, because we know our piece better, but that doesn't mean that we know what to do at school. And unless we're going to learn their system, which is very hard to do, I think what needs to happen is to sit down and say, you know, these are again, back to the functional piece. You know, if we look at on the ground, what does it look like and what needs to happen every day? And then we take all the technical language out of it, both theirs and ours. I think we get to a better place where we can plug the language into the plan, and I'm going back to the plans that need to be written, the ones that have the force of law, and then I think we have a shot. But there's a lot of unpacking that needs to be done to get to that point. And could I just suggest that the woman at the end of the table in the brown jacket, because she's been trying to get in for about 20 minutes.
Thank you. And
Thank
next
you.
Go ahead.
I was interested in your mention of placebo, and I was wondering if there were any contexts where you could imagine a placebo would be appropriate. And I ask because I work with physicians, primarily neurologists and psychiatrists who work with types of medications, primarily for vision disorder patients, and about half of them are using placebo. And we know from the literature that physicians are using placebo. And one of the things, one scenario could be that you take the child off of the medication and their symptoms get worse, which is something I've heard from my physicians mention. And secondly, the medication often anchors them to the physician, so they won't, if they take them off the medication, then they no longer will follow up, and the follow-up will be their problem. And third, the patient may not be amenable to receiving any kind of psychiatric care. So it's a genuine question. I'm curious about what your thoughts are.
So I strongly feel that definitely a full evaluation should be done in any patient who's diagnosed with non-epileptic seizures, trying to understand if there are any psychiatric comorbidities that should be treated. And when I'm saying treatment, it could be psychological, it could be medication, it could be support groups. I think in the case of non-epileptic seizures, using a placebo is not a good idea because you are reinforcing the idea that, specifically when we're thinking about anti-epileptic medications as placebos. And I see it all the time because these patients come, we have the report from the outside neurologist saying, we know this patient has non-epileptic seizures, but in any attempt that we have trying to wean them off the anti-epileptic, the episodes becomes worse. So then I think if we build the groundwork to help the patient and the family understand why these episodes are happening and how can we help them. I think despite that these are non-epileptic seizures, they should continue to get treatment by the psychiatrist even if they're not taking any medication, and they should continue to get support. And if they build this relationship with the neurologist, I think it will be important to continue at least 2 or 3 appointments after the diagnosis was made so they can fully understand what's happening.
Yes, please.
One more question. I'm seeing more adults, so I think it applies to both school and workplace. Isn't it really going on whether they have epileptic or non-epileptic? I mean, I've heard from lots of my patients that they are bullied essentially for whatever condition they have. And does it really matter what the substrate is if that is a particular stressor to their condition? Can they just say, hey, let's face it, you're part of what my problem is. So if you just chill out, back up, and let me be your colleague and not be your puppet or whatever, can that be a little confrontational, or can it be part of the therapy? Just a comment, I have no idea, so I'm asking you.
Go ahead.
It would be nice, but that would just be a reason to bully you even more. I mean, kids, it's a whole other ballgame. It's a whole other ballgame.
And I think, psychoeducation is one of the things that helps the most. So one of the things that we recommend when we have anyone with any patient with epilepsy is to have someone, either from the Epilepsy Foundation to come to the school and try to teach the other students about what is epilepsy, why these episodes happening. Some people might be afraid of these episodes, so trying to teach them what this patient is going through might help them build support and resilience in the other kids. yes, it might be true that some patients might use some of the information to bully the kid more. It's kind of...
We've, as Tatiana says, it is successful when either a parent comes and gives a talk to the class. I've also had some kids themselves with epilepsy who have given talks to the class, and the Epilepsy Foundation. That is helpful, but even then, there still are some schools and classes within the schools where, you know, this is, unfortunately, kids do these things. And then the therapy has to really work on helping the kid how to deal with the bullying.
Yeah, I think it depends upon the bully. I mean, a lot of times kids are singled out and they're bullied because they're different or the other kids don't understand what's going on, so their reaction is kind of to make fun of, you know. But there are certain kids where even if they're educated and they understand, they have some psychological forces going on within themselves causing some anger that causes them to lash out. So
Mary Lou Smith has shown in the studies where she's followed up kids who underwent surgery with epilepsy versus kids with intractable epilepsy who didn't undergo surgery, the biggest difficulty for them all along was this bullying issue, and it was not so much related to the epilepsy actually as to their special learning needs. That was the main thing they were teased about.
Last comment. So, and going back to the bullying, like we are part right now, we're doing a program for bullying prevention, and we were trying to understand and conceptualize the program. So we decided if the program was just tailored for the kids with epilepsy, it wouldn't work. So a program has to be universal. So including the whole school in the program, trying to help this small group of kids. But if you're not including the whole school, it's going to be really hard.